So thank you, Tammy, for inviting me. Thank you, Wake Up Narcolepsy, for inviting me. I'm glad all of you are here. This has been a long time coming. I've had a remarkable interest in narcolepsy and treatment of narcolepsy for as long as my practice has existed, which is now 30 years at Duke University. And I'm finally delighted to welcome all of you to Durham, North Carolina. So let me start off first by asking our AV folks to maybe coordinate this screen with that screen. Perfect, thank you. So as they do that, my topic today is going to be understanding narcolepsy and talking about some myths, some facts, and some latest research that relates to those myths and those facts. Many of those myths you heard about in that introductory video that you just heard. And I'm going to talk about some of those myths, not all of them. I had to take out one myth because my presentation became too long last night. But nonetheless, we're going to go over these myths and then talk about some interesting new research that adds to the facts surrounding those myths. So let's start off. I'm going to get started, and hopefully this will catch up with me. Perfect. These are my disclosures. None are terribly relevant to the presentation today, but I wanted to put these up there just in case. DSMB, by the way, refers to the Data Safety Monitoring Board. These are boards that various pharmaceutical companies will set up as independent observers for their clinical trials to make sure everything is being done safely. Okay, so this is the overview that I talked about, and I'm going to try to build in the latest research with each myth and each fact that I talk to you about. So let's start off. Our first myth: narcolepsy is just being sleepy all the time, and you just fall asleep randomly. And you see these images in lay publications that people just fall asleep just like that, in the middle of a conversation, in the middle of doing something critically important. And I really think that is a myth. Not very many people I've talked to fall asleep like that. I have taken care of many physicians, many attorneys, many people who have very delicate and very tedious and very demanding jobs that they are perfectly capable of doing with a little bit of help. And so this is not an accurate representation of what really happens. Okay, so while sleepiness is a key feature, narcolepsy is a complex of symptoms, of several neurologic symptoms. So what are these symptoms? These are the classic symptoms of narcolepsy. So in my presentation, I'll take a step back and talk about some very introductory items, which I'm sure many of you already know about. But just in case you don't, I've put these up for those of you who are new to narcolepsy. And then I'll talk about some of the more interesting things that more of you may be interested in. But these are some of the typical symptoms that we're taught in medical school and thereafter about what people with narcolepsy may present with. And so notice that excessive daytime sleepiness is there in virtually everyone. Almost 100% of people who have narcolepsy are going to have some element of daytime sleepiness. It may not be very severe, but it's going to be there. Then there's cataplexy. We'll talk about that in detail in terms of what that is and how that might manifest, how that might show up. And then there's this terrifying phenomena of sleep paralysis and hypnagogic hallucinations, which notice is in far fewer people than daytime sleepiness is in. And then the one thing people don't talk about is how terrible their nighttime sleep is. And that seems counterproductive to most people with narcolepsy because you're sleepy all day and it doesn't make sense that you can't sleep at night, but that's really a key feature of narcolepsy as well. Okay, so in terms of how these progress, there's a definite age relationship to these as well. The first thing that will arrive is the daytime fatigue and tiredness. And other symptoms will come in later on, and it may be several years after which cataplexy may show up. So not everything is going to arrive at the same time. So let's talk about the primary symptom first, daytime sleepiness. How does this present? It's not someone falling asleep while pouring their coffee. That's not how this will present. But there is a sense of chronic pervasive fatigue that's present all day. There may be sleep attacks. Sleep attacks are not typically happening when you're actively engaged in something, but when you're maybe sitting passively, it becomes very hard to stay awake. Naps are very common. Classically, we're taught that they're short, 10, 15 minutes, and people feel better after their naps. We'll talk a little bit more about that in a minute, but that's sort of the classic presentation as physicians we are taught to ask for. And then there's automatic behavior that not a lot of us ask about. Automatic behavior is performing a routine task without conscious awareness. And this routine task might actually be driving. This might actually be driving, so missing a few exits or arriving home and not realizing I passed that marker that I always pass, but I don't remember it. Can be terrifying, but that's automatic behavior. Cataplexy. So cataplexy is the key defining feature we're taught of narcolepsy. And that's true, but that's also a little bit of a problem that if you're always looking for cataplexy, we may miss a lot of people who have narcolepsy and not make that appropriate diagnosis. But cataplexy is really a key feature of some people with narcolepsy. And this is the sudden onset of muscle weakness that is often triggered by emotion, but does not have to be. Some people just have it spontaneously, but for most people it's triggered by an emotion. And we'll talk about those emotions in just a moment. It's typically very short. There's no loss of consciousness. In other words, you're perfectly awake when this happens, which is even more terrifying because you are aware of exactly what's happening around you. The big problem with cataplexy is that if it's not full-blown, which it hardly ever is, by full-blown I mean affecting your entire body, if it's very subtle, early on in your life with narcolepsy, cataplexy may not even be known to you. In other words, the weakness may be so subtle that people think this is normal. It may just be a little bit of weakness in the knees, a little bit of weakness in the arms that just passes after a minute or two. And this may be considered perfectly normal by individuals. And I've certainly had folks I have seen for several visits over a year or two. And finally, I asked the right question, which triggers, yes, I have that. And it hadn't up until then. I had not asked the right question. So this is not obvious for many people. But if an individual has cataplexy, they have a particular type of cataplexy known as narcolepsy type 1, NT1. And we'll be talking about NT1 and its cousin NT2, which is narcolepsy without cataplexy. So with or without cataplexy is really the deciding factor that determines whether you have narcolepsy type 1 or narcolepsy type 2. Okay. So we talked about cataplexy. Where does it occur? Which body part? So in the lay publications or in movies and things of that sort, you might see cataplexy presenting as someone falling to the floor. That's actually the most rare type of cataplexy there is. That doesn't happen very often. It often affects the knees buckling, arms weakening, often the face. And these can be very subtle and not obvious to an observer, only obvious to the individual themselves and perhaps the family members who know them very well. And which emotions trigger it? These are the emotions that trigger it. Laughter is by far the commonest. Fright may also, or anger may also do it, but the other emotions are much less commonly triggers for cataplexy. So laughter is it. That's the most common trigger for most people. Let's move on, talk about sleep paralysis. So what is sleep paralysis? This is the inability to move when you wake up or the inability to move as you're falling asleep. It could be waking up or falling asleep. This can be terrifying the first few times it happens. You're perfectly awake, aware of what's going on around you, but you can't move. You can breathe. You might actually be able to even look around the room, but you can't move. Once it's happened 10 or 15 or 20 times, people get used to it. They know how to compensate for it. But the first few times, it can be absolutely terrifying. The problem with sleep paralysis is it doesn't only occur in narcolepsy. It can occur in people who have sleep apnea. It can occur in a normal individual who doesn't have a sleep disorder just because they've had disrupted sleep at night. So just because you've had sleep paralysis doesn't mean you have narcolepsy. Like I said, this can be very frightening as well. And in addition to that, it can often be associated with hallucinations. Hallucinations are very vivid dreams that people with narcolepsy will often have. And these vivid dreams can be very realistic. And in fact, people feel like they've actually lived through this. I've had folks relate to me that they wake up and they've got a bandage on their hand. They think, well, I didn't go to sleep with a bandage on my hand, but now I have a bandage on my hand. What happened? The dream was that I was trying to get out of my house, which was on fire. I grabbed the doorknob, tried to get out, but I burned my hand on the doorknob. And so in that state, this individual woke up, put a bandage on her hand because she thought she had burnt her hand. So dreams can be that realistic. And as physicians, one of the key things we should do is talk about these dreams. Ask about these dreams. Importantly, one of the key features that I tell all the folks that train with me is when you talk to someone who you suspect may have narcolepsy, ask them about their naps and whether they dream in their naps. So dreams happen in REM sleep or REM sleep. When you go to sleep and you don't have narcolepsy, and we're going to talk about this in a moment as well, when you go to sleep and you don't have narcolepsy, it takes about 90 to 100 minutes to go into REM sleep. 90 to 100 minutes, which means about an hour and a half or longer. And that's when you start dreaming. If you take a nap and it's 15 minutes, should you go into REM sleep? No, you should not, because you've not spent that 90 minutes asleep. But if you go and take a nap and within 10 minutes you're having a dream, something else is going on. So if you have dreams in your naps, that's a key feature in the history that we should be looking for. Unfortunately, not very many physicians ask about that. So I've told you about narcolepsy type 1 and narcolepsy type 2. Many of you are probably familiar with this. But the big difference is type 1 is with cataplexy, type 2 is without cataplexy. Many of the other symptoms are similar. But notice here that in type 1, the symptoms tend to be a little more severe, and in type 2, may be a little milder. That doesn't mean the disability is not there for type 2, but the symptoms vary just a little bit between the two. Now, in addition to having cataplexy or not having cataplexy, there's a little thing about hypocretin that we're going to get into in a moment. That also helps us differentiate between type 1 and type 2. But historically, type 1 is with cataplexy, type 2 is without cataplexy. And just because you have type 2 doesn't mean you might not eventually develop type 1. As I said, symptoms change over time and with age. And especially if you're younger, it certainly could happen. Now, those are symptoms that I've told you about. We all learn about this in medical school. We learn about it in our fellowships, in our training programs, and that's what we're trained to ask about. What we're not trained to ask about are the symptoms that really happen. So you know that there's textbook symptoms and then there's life. And we don't typically see textbook symptoms in real people. We see life in real people, and this is how people will present to us. Cognitive problems, thinking problems, I just cannot function. School is much harder, college is much harder, work is much harder. I'm not able to do all the stuff I was able to do, or do it as fast, as quickly, or as accurately. This business of narcoleptic fog, perhaps you've experienced that, but this is a real thing. So we don't ask about those. We don't ask about that cognitive issue. We talk about sleepiness, which is different than cognitive issues, but those are real as well. Emotional disturbances, these are extraordinarily common. And that's not because I'm sleepy all day. That's not the only reason. There are clear brain chemical abnormalities, and we're going to talk about that later on today, that affect this. So it's not that I've been dealt this hand and I'm depressed because I have tiredness and fatigue and I can't do what I... Yes, that may be part of it, but that's not the entirety of it. And there may be other very significant symptoms. Some people have a lot of mental health, emotional issues. This is all part and parcel of narcolepsy that needs to be recognized and needs to often be treated independent of the narcolepsy treatment. The napping patterns, we talked about these short naps that all of a sudden are going to make you feel much better. Most people will present with longer naps, 2-hour naps, that don't feel as great as I thought they should feel. So that's not always accurate as well. And as I am trying to allude to, that this is not just a disorder of daytime sleepiness. There are so many other factors involved. And we haven't even started talking about nighttime sleep. And so all of this then boils down to narcolepsy and type 1 narcolepsy not just being a single condition. It is a lot of different conditions, perhaps, that come together when a patient presents to us in the office. And so what we're trying to differentiate is whether someone might have narcolepsy type 1, type 2, or this whole concept of idiopathic hypersomnia. That's sleepiness due to some other reason, perhaps, a reason that we cannot identify. But in addition to that, the sleepiness may be due to mental health concerns. It may be due to someone who doesn't sleep enough, which whether you have narcolepsy or not, that's a lot of us, by the way. Or it may be medication-induced. You're taking a lot of medications. There's a lot of medications out there that make you sleepy. They may not be related to narcolepsy, to mental health concerns, anything else. You may be taking something for your heart. That may cause sleepiness as well. Okay? So this is the spectrum of sleepiness, if you will. And our job in the office is try to figure out which one of these it is. And it's not always straightforward. And so many of us think now that narcolepsy, based on all of its symptoms, is actually a continuum. Many of you have heard of idiopathic hypersomnia. These are not two different conditions, in my opinion. These are two ends of a spectrum of a condition. And so you've got type 1 narcolepsy on one end, you've got idiopathic hypersomnia, people who sleep 13, 14, 16 hours a day and still don't feel good. And then you've got type 2 and people who have idiopathic hypersomnia but only sleep 8 hours a day. So this is, in my opinion, and many people are now coming around to this type of a concept of narcolepsy, that this is a spectrum, not simply two, type 1 and type 2. You've got one or the other. It's a spectrum. And idiopathic hypersomnia is part of that spectrum as well. All right, let's move on to myth number 2. Narcolepsy is caused by not getting enough sleep. This was alluded to in the videos as well. If you could just sleep a little bit better, you wouldn't have a problem. You'd be fine. And that also is not accurate, of course. Nighttime sleep is extraordinarily disrupted, even if you, and many of you are trying to sleep at night. That is not easy. And as I said earlier, one of the great ironies of narcolepsy is that you're sleepy during the day, but cannot sleep well at night. So what do I mean by that? So fragmented nighttime sleep is a key feature of narcolepsy. Again, one that physicians may not ask you about. And what I mean by this is that it's frequent nighttime awakenings. People wake up very often during the night. They may be confused and disoriented depending on which stage of sleep they're waking up out of. Their days and nights are screwed up. Some people feel like they're staying awake during the night but falling asleep during the day. It doesn't make any sense. And as soon as they fall asleep, they start dreaming, go into REM sleep. How do you know you're going into REM sleep? If you're dreaming. Dreaming happens in REM sleep. Now, even if you don't remember your dreams, you may be going into REM sleep. But certainly if you remember your dreams, you have gone into REM sleep. And sleep intrudes into waking hours. Instead of being awake in a lecture like this, you start falling asleep. It may be because I'm boring, but even otherwise, you may be falling asleep. So, fragmented nocturnal sleep. This is what a normal sleep pattern will look like overnight. So let me just walk you through it. This is known as a hypnogram in our world, but what this shows you is top in blue, light blue, is wakefulness. And then midnight happens. Hopefully you're going to bed a little bit earlier, but okay, you're going to bed at midnight. You go in and you go into non-REM sleep, non-REM sleep. And then after, remember, 90 minutes, you go into REM sleep, then you go back into non-REM sleep, and so on and so forth. You cycle through the night, and then 8 o'clock, you're ready to go, wake up, and then you're awake. This is a normal sleep pattern. What happens in people with narcolepsy? This is the sleep pattern of a patient with narcolepsy. And so notice that your daytime is not one continuous blue line, it's interrupted. You see that non-REM sleep is intruding into wakefulness, and REM sleep is intruding into wakefulness. And that intrusion is when you fall asleep and start dreaming. And then look at what happens at night. You don't have that nice cycling of sleep stages throughout the night. You have this disruption, waking up, going back to sleep, waking up, going back to sleep. So this is fragmented nocturnal sleep in people with narcolepsy. So you think that, okay, people with narcolepsy have this fragmented nocturnal sleep. How do we capitalize that in terms of diagnosis? If you're not sleeping well, can I use that information and come up with a diagnosis of narcolepsy? Well, interestingly, I'm going to tell you about some new work that's been done, very recent, on looking at this very issue. So this was using AI in analyzing sleep of people with narcolepsy. So in this study, they took the data from people who had narcolepsy, all of the sleep data, the sleep studies that many of you have probably had. You take this data, a technologist will review it and score it. They'll figure out whether each minute, each 30-second period is awake, asleep, and what stage of sleep. They do this with 3,000 people with and without narcolepsy, analyze it, and come up with a marker for NT1. Now, NT1, we're looking at a particular subset of people with narcolepsy, NT1, and they created a marker based on AI analysis of these records. And they found that if they use this marker and look at the overnight sleep, they had a remarkable efficacy, a remarkable sensitivity in picking up narcolepsy. 91% of the time they got it right. And what does that look like? This is their marker. So this is normal sleep. So let me just walk you through the color coding here. White is awake. N1 is early sleep. N2 is typical medium sleep. N3 is deep sleep. And in black is REM sleep. So notice what happens in a typical individual who doesn't have narcolepsy who goes to sleep. You see that they are initially awake, white. They start becoming drowsy, red. They go into medium sleep, light blue. And they go into deep sleep, dark blue. And eventually into REM as well. Guess what happens in people with narcolepsy? So with an AI-driven model, I don't even have to walk you through this. There's an obvious difference. There's a difference in when stage 1 is occurring, when wakefulness is occurring, when REM is occurring. And so you can use these powerful markers and pick up folks who have narcolepsy or who may be suspected in having narcolepsy. Is this real available today? No, absolutely not. But these are the advances that are being made in terms of getting to the correct diagnosis. Let's move on to myth 3. 3 has 2 parts to it. Part 1, 3A, the cause of narcolepsy is unknown, and 3B, very much related to that, narcolepsy is caused by vaccines. Perhaps a very contemporary topic. Vaccines are in a lot of discussion these days. So let's talk a little bit about whether this is a myth or a reality. So the cause of NT1 is well understood, and I'm going to talk about that. NT2 is less clear. And do vaccines cause narcolepsy? Well, there's no clear evidence that they do, but let me show you some data. You make up your own mind. Before we talk about what causes narcolepsy, I want to just take a step back and talk a little bit about what happens in the brain to keep you awake and allow you to fall asleep, allow you to go into REM sleep as well. Now, this is not going to be in a lot of detail. It's pretty simplistic, but it will give you an idea of what's happening in your brain that causes the narcolepsy symptoms and what keeps you awake. It may also help you understand why some medications work, how they work, and perhaps why they don't work in some people. Okay, so the first thing we'll talk about is why do you stay awake? How do you stay awake? So on your right is a cross-section of the brain. It's as if I'm looking at it straight down like this. So if you were to place your eye, it would be somewhere over here, somewhere over here. So this is the front, this is the back of the brain. Okay? And you're looking at it in cross-section right through the middle. And there's a couple of important parts of the brain that are very important to us, and that's the thalamus and the area below the thalamus known as the brainstem. The brainstem is the lower part of the brain. The lower part of the brain is absolutely critical. It helps us stay awake, go to sleep, and it controls our bodily functions. It doesn't help us think, but it does everything else. The top part of the brain in blue is what helps us think. Okay, so two parts. The top part is helping us think. The lower part is keeping us alive. Okay, so for sleep, our key features are going to be, for wakefulness, these are all brain chemicals, neurochemicals that help us stay awake. So there's a lot of them, and we need all of them. And they work in different parts. So acetylcholine, you see it over here in this part of the brain. Dopamine, you've heard a lot about dopamine, I'm sure, right over here. Histamine, right close to it. Norepinephrine, also close to it. Serotonin, also very close to it. All in one tight location of the brain. All these chemicals are helping us stay awake. If we lose these, it becomes harder for us to stay awake. If we take a medication that opposes one of these, we get drowsy. As an example, you've heard of antihistamines. You take those for colds and things of that sort. What happens when you take them? You get drowsy. Why? Because you're knocking off your histamine that helps you stay awake. Okay, in addition to that, there's a key other neurochemical that I haven't told you about. That's orexin. Orexin is central to understanding what's wrong in narcolepsy. Orexin, much like all these other chemicals that helps us stay awake, supplements these other chemicals. It projects to the front, the big part of the brain, helps us stay awake, and it helps all the other neurochemicals come along as well, and it really helps us stay awake. In addition to that, it turns off the centers in the brain that cause REM sleep. So the orexin, when it's there, helping us stay awake, turning off REM sleep, making us productive. A key critical element that's needed. But there's one other thing that orexin does that we don't talk about very much. It's not responsible, but helps with energy metabolism. Why is that important? We'll talk about that later on as well. But when you lose energy metabolism, all of a sudden it's hard to lose weight. You start gaining weight without doing anything different. So energy metabolism is also something orexin does. In fact, the name orexin was given because of its relationship, originally thought to be predominantly food-related, not sleep-related. Only later did we learn that it's predominantly a sleep issue. All right, next is sleep. What helps us sleep? Indeed, there's a center in the brain that helps us sleep. You see it right there in red. And the main neurotransmitter, main chemical there is something called GABA. So 5 different ones that help us stay awake along with orexin, 1 that makes us sleep. And so you know that many people have difficulty sleeping at night, and they may have issues with this. So that's something to keep in mind as well. And finally, REM. There's a center in the brain that helps us go into REM sleep. This center has to be turned off when you're awake. And it periodically is turned off when you're asleep. Not all the time, because you're not always in REM sleep. You're only in REM sleep for particular times of the night. So this center needs to be turned off. And when you can't turn this off during the day, that's when you have cataplexy. So these are all key critical features in helping us stay awake, allowing us to sleep, allowing us to go into REM sleep as well. So what happens in NT1, narcolepsy type 1? What happens in narcolepsy type 1 is that you lose that part of the brain known as the hypothalamus. I showed you where the thalamus is. Right below it is the hypothalamus that contains these orexin brain cells. So orexin is really important. It sort of organizes everything. You lose those organizing cells. And what's shown over here is that this little blue area is where the orexin lives. You lose those in NT1. Orexin goes away. Coordination in your sleep and wakefulness is gone. and that's what produces NT1. And if you do a cross-section of it and look at those cells that contain orexin, this is what you see. On your left in this figure, the black dots are brain cells that contain orexin, and on your right is a patient with narcolepsy, obviously on autopsy examined, and you look at those black dots and look at how fewer they are compared to someone who doesn't have narcolepsy. But this is NT1. What happens in NT2? We're not entirely certain what happens in NT2. Could it be that the loss of these orexin-containing cells is there, but just not as bad? Remember, I talked about how NT1 symptoms are a little bit worse than the NT2 symptoms? That is not proven yet. So, NT2 remains a little uncertain. NT1, we know pretty well what does it. Then, vaccines. So let's talk about autoimmune diseases for a moment. What are autoimmune diseases? So our immune system, you've heard a lot about immune system in the last 5 years with COVID. You've certainly heard about how your immune system may be compromised or could be compromised, or if it's compromised, how more susceptible you are to COVID. But our immune system is our internal defense system. When viruses or bacteria or whatever else attacks us from the outside, and they do every single day, every single moment, you're breathing in bacteria, viruses, and so on and so forth, but your internal immune system is fighting them all off. When it can't fight them off is when you have a cold or you have an infection or whatever else, but 99% of the time, your immune system generally is successful in fighting these things off. Every once in a while, your immune system goes awry. So instead of recognizing that virus or bacteria coming from the outside, something inside you is now recognized as an abnormal stimulus, and it starts to attack that thing inside you. And one of the things that might happen is a critical organ might be recognized as an external threat. And you see that autoimmune diseases, when that happens, can affect virtually every organ, from your heart to your brain to your lungs to your kidneys to your blood. Virtually every organ can be affected by autoimmune diseases. All right, so how does autoimmunity relate to narcolepsy? Well, there are particular cells that are involved in autoimmunity. And what happens is that when there's an external threat, our cells attack this external threat, recognize it as an abnormal phenomena, and kill it. But if something else inside our body, and in the case of narcolepsy, it's those hypocretin-containing neurons, look exactly like that outside threat, those cells start to attack that as well. So in a lot of people who develop NT1, we go back and ask, when these symptoms started, was there something that happened 6 months, a year, a few months before the symptoms started? And some of them have had a cold, infectious mononucleosis, or something like that. And after that, the symptoms start. So your immune cells recognize that as an abnormal threat, but your hypocretin-containing neurons were very similar, so it attacked those as well. And the net result? Narcolepsy, type 1. Okay? So autoimmunity. Now, why am I stressing on this? Because if that's what's happening, maybe there is some treatment we can institute for that. Okay, so this slide is a little light, but this stresses the point that when autoimmunity happens like this, if it's affecting the brain, it could affect other organs as well. So a lot of people who have NT1 have other autoimmune conditions as well. And those autoimmune conditions can affect your bones, your joints, your heart. And so very often we see people with narcolepsy develop diabetes, arthritis, lung conditions, and especially ones that have NT1. So autoimmunity is a key part of narcolepsy as well. So just to wrap this section up, COVID-19 and narcolepsy. So I talked about vaccines. And in fact, some of you may remember the H1N1 pandemic many years ago. And it was particularly bad in China. And they saw about 10 years after that an increase in incidence of narcolepsy in people who had H1N1. Could the same happen with COVID? We're not that far out yet that we know the answer to that, but this is one study that was published last year that looked at people who had so-called long COVID. Out of these 500-some patients, you drill this down, about 3 or 4 of them have problems that are consistent with either narcolepsy type 2 or idiopathic hypersomnia. Again, remember I showed you the continuum. Are these different conditions, or are this all part of one big condition? So the jury is really out on this. And 3 out of 530, that's actually not a low number. Remember, type 1 narcolepsy or narcolepsy is 1 in 2,000 individuals. So 3 out of 530 is actually a pretty high number. So where is this going to end up? I don't know. But this is, by the way, not COVID vaccination. This is people who get COVID. Okay? So something to keep an eye on. We'll learn about this in the next 5 years, perhaps in the next 10 years, but certainly something to keep an eye on. Okay, myth number 4. Narcolepsy can be diagnosed by a sleep study, MSLT in particular. This is my favorite pet peeve, if you will. And so a lot of my trainees say, well, he doesn't have narcolepsy because the test didn't show it. And that's absolutely false. Okay, that's absolutely false. So a best diagnostic test for narcolepsy, simply one, and that's history. That's talking to someone and finding out what's going on with them. Get a true sense of how their symptoms started, how did they evolve, rather than simply looking at a test. Now, why is this the case? You all know if you have narcolepsy, you've gone through sleep testing, and you didn't get a diagnosis of narcolepsy until that test came back positive. And if it didn't come back positive, then many people don't get that diagnosis, which is unfortunate. But let's talk about that. Well, first off, what is narcolepsy? How do we define it? So, our Bible, if you will, in sleep medicine, in terms of how we classify conditions, is called the International Classification of Sleep Disorders. When I started practicing, we were in the first iteration of this. In fact, it was before this came out. But now it's in its 3rd iteration, and it's modified continuously. And now we define narcolepsy type 1 and type 2 along the following ways. Basically, it's someone who's sleepy for more than 3 months. 3 months because everyone can be sleepy for short periods of time because of any acute illness or stress or whatever else have you. But in type 1, you must have one or both. In fact, you need to have both, one or both of these 2 things. And one of those is cataplexy as well as an MSLT, a daytime sleep test that has abnormalities in it. And that is, you fall asleep within 8 minutes, and you have at least 2 naps in which you go into REM sleep. Or you have a CSF evaluation, a spinal fluid evaluation that shows a low hypocretin level. Now, that second part is very difficult to do because there's only one lab in the country that really tests that, and you need spinal fluid, which is also quite difficult to get. But nonetheless, to get this diagnosis, most people will get a sleep study, and you can see here what is required in that sleep study. You need to fall asleep quickly, and you need at least 2 episodes in the nap study to go into REM sleep. Type 2, you don't have cataplexy, but you still need the MSLT findings I just told you about. So you must have positive MSLT findings in order to get that diagnosis. Okay? Now, here's the problem. Here's the problem. So the problem is that in order for you to get this diagnosis, you must have a positive MSLT. But if you look at people who have cataplexy, remember I told you cataplexy is the key feature of narcolepsy. If you have cataplexy, then it's almost nothing else that you can have. It's got to be narcolepsy. If you have cataplexy, only 80% will have 2 episodes of sleep onset REM in that nap. Only 80%. That means there's 20% of people, 1 out of 5, that won't get that diagnosis even if they have cataplexy. And then if you look at people who don't have cataplexy, only half will have those 2 episodes of REM sleep. And half of them will not. So even if they have cataplexy, even if they have narcolepsy, they will not get that diagnosis because they don't fit this criteria. But this is not a very accurate test. We are using a test to diagnose narcolepsy that's not very accurate, and that's my point. Not only that, how often do people factor age into all of this? We never look at age, but in fact, when studies have looked at whether a MSLT, a daytime sleep test, is positive based on age, we see a big change in the age range. So more likely to be positive between 21 and 35 years of age, but much less likely to be positive when you're even younger or certainly as you get older. And again, the positive test that we're really looking for is this one that's highlighted. And you see how these numbers change with age. So and you heard many people talk about how their diagnosis was delayed 10 years, 15 years. So if symptom onset was age 25, you're not getting diagnosed till age 35, 40, your probability of having a positive MSLT keeps going down. And there's many other slides I could show you about the inaccuracy of an MSLT. For interest of time, I won't. And that's my big problem with saying that you need to have a positive test in order to have a diagnosis of narcolepsy. This becomes even more important because in today's environment where drugs are approved for certain conditions and insurance will not allow us to prescribe drugs that are not approved for a certain condition, even if I think someone has narcolepsy but the test doesn't show it, insurances will tell me that I cannot prescribe this drug because the test did not show it. So that's what really becomes frustrating is I've got drugs that may potentially work. I can't prescribe them because they're not approved for this particular condition. So that becomes a real challenge, and it's really unfortunate. How might we fix this problem? Well, many of you know that there's wearables and so on. Many of you probably are wearing something that's tracking your motion, tracking your sleep on a daily basis. These are pervasive. A lot of the population now has these devices just for general health concerns. And they can be very helpful. I often will, I'm sorry, this probably doesn't project. I don't know if we can dim the lights a little bit, but that's okay. You don't really need to look at exactly what's on the slide. But the point here is that when you look at the data that's being generated by these devices, you can look at your sleep stages. Is it 100% accurate? Maybe not, but it gives you a pretty good idea of what's going on. And if you don't have a sleep pattern that I showed you for relatively normal, if you will, people, and you're going into REM sleep the moment you fall asleep, and you've got multiple episodes of REM rather than 3 or 4 or 5, maybe that's something that is significant. Maybe that's something we ought to be looking at. Everyone, not everyone, a lot of people are wearing these devices. Should we be looking at these to help get to the diagnosis? If our primary source of diagnosis, that MSLT, is so inaccurate, will these things make it more accurate? And indeed, people have started to look at that. And this is one study that was presented last year at the sleep meeting. Had more than 500 participants that identified themselves as having narcolepsy. The wearables looked at their sleep overnight, looked at their daytime functioning as well. And when they subjected this again to AI algorithms to try to figure out what's going on, they came up with a calculator that was 80% accurate in detecting undiagnosed type 1 narcolepsy. 80% accurate. So arguably that's as accurate as the MSLT for type 1. We don't know what happens in type 2 yet. But this is just living your life, wearing this thing for a week, 2 weeks, rather than going for expensive sleep studies. Is this a wave of the future? Potentially, if we can get enough data that these things are accurate. Perhaps wearables is all we need. We do this for 2 or 3 weeks. We get enough data to understand whether sleep schedule, your sleep habits and your sleep that you're getting overnight is consistent with that in someone who might have narcolepsy. All right, myth number 5. There are very few effective treatments for narcolepsy. Well, that, of course, you know is a myth. And indeed, there are many effective treatments that are already on the market and there are many new ones that are being discovered. And I'm going to talk mostly about the new ones because I think it's absolutely fascinating, and you'll have to recall some of the things we talked about early on in terms of how narcolepsy happens, in terms of how these treatments might be effective. So this is the list of what's available now. Now, the ones that have little asterisks by them are ones that are FDA approved for the use in narcolepsy, in daytime sleepiness, and in cataplexy. Now, why do I think that's important? That's important because if these medications are new equals expensive, by the way. If these medications are new, then it's very hard to prescribe them unless you're using them for the indication for which they were approved. Insurance will not allow us to use them. So even though they might work, you can't use them. But notice that there's not that many. I mean, there's a whole list of medications up there. We use a lot of these meds, but only a few are approved by the FDA. Now, we can have a whole discussion about why more are not approved by the FDA. That's probably another hour-long, day-long discussion. I'll skip that. But that is one of the challenges for these medications. So again, there's a lot of them. You can use them for daytime sleepiness. You can use them for cataplexy. And you know that there's medications to help you sleep better at night as well. So they're all there. So let's talk a little bit about what's coming in the future. New medications for wakefulness. So there's a couple that are approved already. You know the top two are already available. The first one is the brand name Sunosi, that's currently available. And the second one is WakeX, also currently available. How do they work? Well, the first one, Sunosi, I'm showing you works on norepinephrine and dopamine. Those are two chemicals we talked about. They're helping you stay awake. That's where they live. Those things help you stay awake because this medication increases the amount of those neurochemicals. Okay? WakeX, on the other hand, is a histamine medication. And so that works in a different part of the brainstem. But that's how we can target different parts of these wake-promoting neurochemicals and enhance one or the other and make them more effective. Now, you can say, well, why don't you just enhance all of them? Well, one, that's not that easy. But just because it's affecting that part of the brain doesn't mean it's not affecting other parts of the brain. And when it affects other parts of the brain, that's when you start running into side effects. Okay? And then you've got some new medications. Here, the asterisk means these are not yet approved. They're still being investigated. And so Samilesant is, again, a histamine medication. Flecainide is similar in how it works to another drug many of you might be familiar with, modafinil, and that works on dopamine. Oops, sorry, went too far. And then there are methylphenidate, Ritalin analogs. They're just different types of Ritalin. This one is a prodrug, meaning it breaks into Ritalin. Once you take it, it gets metabolized in your body, and then it becomes Ritalin. So it becomes a longer-acting medication, and that works on dopamine as well. So it's fascinating how you can take different parts of the brain system that helps you stay awake and activate different parts of it to get the effectiveness that you're looking for. Now, the real fascinating thing, I told you a lot about how orexin is really the cause for NT1 and perhaps also related to NT2. We know that there's a deficiency of orexin in the brain in people who have narcolepsy, type 1. What if we were to give this orexin back? Bring the orexin back and make it more active. These are medications that are trying to do that, all investigational at this point. And in fact, what if you knock out the orexin even more? What would that do? Make you sleep. And indeed, medications are available on the market that knock out the orexin that help you sleep. Those are sleep agents for people who have insomnia. And indeed, there are medications that are currently available that help you sleep. These are promoting the GABA system in the brain. And you see a few of them listed here. And there are drugs being developed that help reduce cataplexy. Now, some of the other drugs I've already talked about help reduce cataplexy, but these drugs specifically will target that part of the brain that is controlling cataplexy. So Reboxetine is not yet available, but atomoxetine is. That's also known as Strattera, used for ADHD, but it may also be effective in cataplexy because it affects that part of the brain. And we may have medications that can help reduce that autoimmunity that I talked about. And so these are all drugs, some of which are available, but for other conditions, some that are being investigated, and they would prevent those immune cells from recognizing hypocretin cells as being alien, as being foreign, as being dangerous, and prevent their destruction. Non-medicinal approaches as well. Can you modify your diet? And indeed, many of you may have experienced when you have a big fatty meal or you have carbohydrates, pasta, bread, right after lunch you're sleepy. And that's a well-known phenomena. We looked at this a number of years ago, had a series of patients who had narcolepsy, put them on the Atkins diet, and looked at what happened to their sleepiness, their cataplexy, their hallucinations, and all of this else. And there was indeed a decrease in all of these. Now, is it enough to get off your medications? No. But in addition to the medications, can diet help you manage some of these symptoms better? Yes. And then there's other real out there therapies. There are gene therapies and cell transplant therapies. These are no less than 5 to 10 years away, but this is also being worked on. And so I'll wrap up by reminding you that narcolepsy, as all of you know, is not a daytime phenomena. It's not a daytime sleepiness condition. It affects every aspect of your life, including sleep. The sleep patterns are uniquely disrupted. There's much progress being done, already has been done, in determining the causes of narcolepsy. The diagnostic test of choice to date is getting a history, not doing a sleep study. And there are many exciting new treatments that are being developed, that are already out there, that can really help people restore quality of life, restore your ability to do everything that you want to do, or almost everything you want to do. So I'll end with that, and I'm not sure if we have time for questions, but I'm around all day. Thank you. 10 minutes, okay. Tammy says we have 10 minutes, so happy to answer any questions. Yes, ma'am.
You mentioned that there's only one lab that does the...
Hypocretin levels?
Yes. I had a chance when I was younger and passed on that because of all the side effects. I'm in my second study where it mentions having that done, and I'm willing. I really want to have it done, but I can't find anywhere that'll do it.
And that's what you're describing is very common. It's hard to get those labs done. It's also important to realize that if you have type 1 narcolepsy, that test is going to be positive. If you have type 2, it's not likely to be positive. Type 1 narcolepsy is not difficult to diagnose. The MSLT is more likely to be positive. You're going to have symptoms that are characteristic, so on and so forth. So what you're describing is the key problem with the hypocretin level determination. In other words, it requires a spinal tap, which patients may be willing to go through, but then you got to find the right lab and ship it to them, whether it's done at Mayo or through LabCorp. I'm not sure which one of those two is currently doing it, but it's not done very often, and so they don't really offer it all that readily. Thank you.
What I see a lot in my practice are patients who seem to clearly have narcolepsy, and then when they go to a sleep specialist or a sleep doctor, they're automatically given a home sleep study. So how do people advocate, like what would you recommend if they're given the home sleep study and then they're told, yeah, you don't have apnea, you're fine? How do you work through that system? Because home sleep studies are so prevalent now that that's kind of like the gold standard, but people don't appreciate that that's not for all sleep disorders.
Yeah, no, that's a great question. I deal with this on a daily basis. So home sleep studies are a screening test for sleep apnea. A screening test for sleep apnea. Now, a screening test means that if you're positive, then great, you've got it. But if you're negative, that doesn't mean you don't have it. You should actually go back and get a sleep study. So it's a screening test for sleep apnea. It's much cheaper than a sleep study. So many insurances have said, okay, everyone who gets a sleep study must first have a home sleep apnea test. And I have sent people to get a sleep study and an MSLT, and I've been told that, no, you don't have a home sleep apnea test first. And I said, well, wait a minute. I'm not even suspecting sleep apnea. This is a 20-year-old, thin, young individual who likely, there's no chance has sleep apnea. And I'm told, well, it doesn't matter. You got to get a sleep study, a home sleep study. Why? Because they may have sleep apnea. I said, well, I don't suspect sleep apnea. It doesn't matter. I said, well, I don't suspect that she has a brain tumor. Do I need to get an MRI? No, I don't need to get an MRI, but I need to get a home sleep test. And so the issue is, sometimes those roadblocks are there. And so what do? I do the home sleep test. Guess what it's going to show? No sleep apnea. But then it behooves me to do the next step, which is to do the sleep study, which many insurances will then approve. Yeah. So you gotta follow through. The problem that I see is not that people don't follow through, it's people don't suspect. So for the vast majority of physicians that you will go to, especially non-sleep doctors and even sleep doctors, the one thing that makes you sleepy is sleep apnea. The second thing that makes you sleepy is sleep apnea. The third thing that makes you sleepy is sleep apnea. So when you don't have sleep apnea, then too bad. Yep. So that's where you have to then advocate for yourself.
Thanks.
Hi, this was the first time that I heard about narcolepsy and autoimmune disorders. Are you saying that it could be an autoimmune condition or that it's just comorbid with a lot of autoimmune conditions?
Yeah. So important for me to clarify that when you think about autoimmune condition, I want to separate two types of autoimmune conditions. So one is an autoimmune condition where your immunity is compromised as you're going through it. So in other words, you could have something like a rheumatological condition. There's many types of arthritides that are autoimmune. And so when that happens, your immunity is compromised. So in other words, those are people that kind of walk around with masks even to this day because they're more susceptible to having COVID or other types of infections. That is active autoimmunity. Then there are conditions where you have an autoimmune attack that happens a one-time thing. It happens, causes the problem, and then your immunity is fine. That's narcolepsy. So it happens, does it, then your autoimmune is... So people with narcolepsy are not at greater risk of getting COVID than someone else. If they don't have other autoimmune problems, that is. Just the narcolepsy itself doesn't increase that risk. So that's an important distinction. So it is still an autoimmune condition in that the destruction of the hypocretin-containing cells or the orexin-containing... By the way, hypocretin, orexin, same thing. Those cells are damaged because of the autoimmunity, but once that damage occurs, then that's done, and then you live your life. Over here.
Okay, I tried to narrow it down to one question. So I don't know if it's just a thing that in the community that people are aware of, or like it's more well known now. But the last time I had surgery and I had anesthesia, and I woke up and you're like, "Don't make any major decisions today. Don't do that." I said, "You know what? I feel more awake than I ever had in my life before." So the anesthesia has something to do with it. Lasts a couple days. When we have it, we feel awake. Is that something that's being looked into of why that is? Because that felt amazing.
Yeah, no, that's actually a pretty well-known phenomena, and it is not just anesthesia. It depends on the kind of anesthesia that you have. I suspect you got a drug called propofol. Propofol is a very effective drug, and it gets you into deep sleep. And as I said, many people who have narcolepsy have problems with going into deep sleep. The sleep that they get is not good quality. So what propofol is doing is fixing that problem, but temporarily. And there's people, as you probably are aware of, that have died who have tried to take propofol at home. One very famous example everyone knows of, yes? MJ. And so obviously not something to do at home, but that's presumably why he was taking it, because he was going into deep sleep, and it was wonderful initially until it wasn't. So yes, that's the thing. Unfortunately, we can't translate that into use at home because you can't use it at home, but that's the concept of other drugs that increase the amount of deep sleep that you get. We do have medications that increase the amount of deep sleep that you get. Oh.
So I really appreciate the talk you gave today. Your 2004 article of diet and narcolepsy actually inspired my pursuit in my master's in nutrition to look further into diet and narcolepsy. And I was curious as to why you specifically chose or focused on the Atkins diet compared to the keto diet, which is completely cutting out carbs entirely.
Very simple reason. Keto is much harder. And so you know, I actually am someone who uses the ketogenic diet. As Tammy alluded to earlier, the other part of my practice is epilepsy. And so a lot of, especially younger kids who have very bad seizures often go on the ketogenic diet, which is more severe than the Atkins, not severe, but harder than the Atkins diet, more restrictive at least. And that ketosis becomes very helpful to control their seizures. That same ketosis is helpful in keeping people awake. You don't need that degree of ketosis. Now, if you could do it, it probably would help even more, but it's just much, much harder diet to follow. And the ketogenic diet, are you a nutritionist?
Studying
to be. So you probably know a lot more about this than I do, but my understanding is it's very hard for adults to stay long-term on a ketogenic diet. But people do fine on an Atkins diet. I mean, it used to be quite a fad, if you will, for a long time until it wasn't.
This is kind of a curiosity question. I've read some articles about postmortem autopsies on opioid addicts from UCLA and them having elevated levels of hypocretin and like mice being genetically modified to not produce hypocretin and like reduction of narcolepsy symptoms like cataplexy in those genetically modified mice. Is there any merit to that? And like in like case studies I've read of long-term, like moderate amounts of opioids releasing narcolepsy symptoms, is there any like clinical research into that, or is that kind of obsolete with the legal liabilities, the kind of other treatments?
Yeah, I'm not exactly 100% sure what which studies you're alluding to, but coming back to sort of the effects of narcotics on narcolepsy-type symptoms, I think it becomes very challenging because the patient population in which we see that in, there's a lot of comorbidities. There's a lot of other things going on in those individuals. So I'm not aware of active research that's looking at that very aspect, but there may well be. I don't know.